Hello, I am Jolie Long with the National Board for Certified Counselors. On behalf of the Medicare Mental Health Workforce Coalition, we would like to welcome you to our webinar today. The Medicare Mental Health Workforce Coalition consists of organizations that collectively represent providers, clients, patients, and other stakeholders. Our overall mission is to increase access to client choice for mental health provider care. Together, we achieved this goal with the passage of the Mental Health Access Improvement Act. The coalition is now working to ensure successful integration of counselors and marriage and family therapists into the Medicare program. The coalition members are listed on this slide. Next. At the conclusion of the webinar, you will receive a link to the session evaluation, which you will need to submit if you wish to receive continuing education credit. We will only be providing credit for live attendance of this webinar. The webinar will be recorded and made available on the NBCC website and other coalition member websites for viewing purposes only. The PowerPoint slide link is posted in the chat. Due to the large number of attendees, the participants will remain in listen-only mode throughout the meeting. The presenters will be taking questions at the end of the session, so please feel free to type your questions into the Q&A box at any time. Please keep in mind, presenters are only able to address general questions, as the integration process for counselors and MFTs is in the development stage. We will be hosting another webinar on May 5th that will address more specifics, and we will focus on questions collected during this webinar. Next. Today, you will hear from experts on the key components of the Medicare program, including mental health benefits that beneficiaries receive, how the Centers for Medicare and Medicaid Services, or CMS, will implement Part B coverage of MFTs and counselors, key components of the Mental Health Access Improvement Act that are now law and will go into effect in 2024, and implications for practitioners. I would now like to welcome NBCC and Affiliates Board Chair, Mona Lisa McGee-Barata, to provide opening remarks and to introduce our speakers.
Thank you so much, Jolie. Good afternoon. On behalf of the National Board of Certified Counselors and the Medicare Mental Health Workforce Coalition, I'd like to welcome you to this webinar outlining our historic inclusion in the Medicare program, many years in the making. The passage of this legislation would not have been possible without a cadre of mental health organizations and all of their constituents coming together to advocate on behalf of counselors and marriage and family therapists. Our joint advocacy efforts were years in the making. Many paved the way for this to be a reality today for all of us and for those we serve in the future. Our joint advocacy efforts have steadfastly demonstrated the outstanding training and skills that counselors and marriage and family therapists possess that uniquely qualify them to provide safe and effective care to Medicare recipients. Our joint advocacy efforts must continue as we now pivot to the implementation and identifying how we can best serve the underserved populations of individuals in need. Our joint advocacy efforts will continue to support the Center for Medicare and Medicaid Services, CMS, in developing specific rules on how counselors can apply provider status, receive provider ID numbers, and bill for services. The rules will be developed in 2023 ahead of the January 1st, 2024 implementation. Congratulations to all that have worked towards this movement. And we hope this webinar will help prepare everyone for the important time in our profession. The inclusion of counselors and marriage and family therapists in the Medicare program speaks to the growing need for mental health services and how we can address those needs in the United States and worldwide across all populations in need. Please note, this is only the beginning of the process for NBCC and the coalition. and we will share specific enrollment and reimbursement details as they become available. I'd like to also, in addition to the coalition, I want to thank the NBCC team members for their role in bringing the webinar to fruition. Thank you to Jolie Long, Joel Miller, Nikki Yamone, Rachel Summers, Tammy Hoberman, and Tim Cox, and many others behind the scenes today to make this a reality for all of us. I would like to also thank Dr. Kylie Dotson-Blake, National Board of Certified Counselors CEO, for her tireless efforts and advocacy for the profession and for those most in need that we serve. I will now introduce you to our speakers for today's webinar. First, we're very fortunate to have Meredith Freed. She is a senior policy analyst with the Kaiser Family Foundation program on Medicare policy. At the foundation, she performs research and analysis on a broad range of issues relating to Medicare and the population it serves, including behavioral health care, Medicare spending and financing, and Medicare Advantage. She has authored several reports on Medicare behavioral health policy issues and implications for providers and beneficiaries alike. I'd also like to introduce you to Dr. Matthew Fullen. He is an associate professor at Virginia Tech, where he teaches in the counselor education program. Dr. Fuller's research, teaching, and advocacy focus on mental health needs of older adults, with an emphasis on addressing gaps in Medicare and mental health policy, developing programs to enhance the resilience and wellness. Dr. Fuller is the counseling professional's most active scholar on aging and mental health, with 34 peer-reviewed publications. So we're very fortunate to have Meredith and Dr. Fuller to help support us in these efforts. I now welcome Meredith Freed to begin her presentation.
Thank you, Mona Lisa, for that introduction. Good afternoon, everyone. Thank you so much for having me today. Next slide, please. Next. I think one more, next. There we go. I'm going to jump right in and talk about the Medicare program and coverage of mental health and substance use disorder services. Next. For those of you not familiar with KFF, we are a nonprofit, non-grant making organization focusing on national health issues and serve as a nonpartisan source of facts, analysis, and journalism for policymakers, the media, the health policy community, and the public. Next. Medicare is the national health insurance program that serves 65 million people ages 65 and older, and younger adults with long-term disabilities. It is a social insurance program with defined benefits and is financed by a combination of payroll taxes, premiums, and general revenues. Medicare beneficiaries represent 20% of the US population, and Medicare comprises 10% of the federal budget. Medicare continues to be a very popular program, and a majority of US adults, over 80%, view the Medicare program favorably. Next. So as you may know, Medicare is comprised of different parts. So Medicare Part A covers inpatient hospital care, skilled nursing facility care, hospice care, and some home health services. There is a Part A deductible of $1,600 per benefit period for inpatient hospital stays and daily copays for extended stays. Part B covers outpatient services, including physician services, outpatient hospital care, preventive services, and more. The standard Part B premium is $164.90 per month, though some people may pay more depending on their income. There's also a deductible of $226 and 20% coinsurance for many Part B services. Part C, which is typically called Medicare Advantage, provides all Medicare covered benefits, so there's Part A and B benefits, through private plans that contract with Medicare, such as HMOs and PPOs. And Medicare Advantage plans also typically include Part D prescription drug coverage. So Part D covers prescription drugs provided by private plans that contract with Medicare, including standalone prescription drug plans, as well as plans that are as part of Medicare Advantage plans. So just to recap, when people sign up for the Medicare program, they have the option of traditional Medicare, sometimes called original Medicare or fee for service, or they can choose Medicare Advantage. If they choose traditional Medicare, they also might choose to purchase a standalone prescription drug plan, and they might also choose to purchase a supplemental Medigap policy, which covers some Part A and B cost sharing. If they don't choose traditional Medicare, they can choose Medicare Advantage, which covers all of the Part A and B benefits, typically includes Part D prescription drug coverage, and covers some benefits that traditional Medicare doesn't cover. And I will come back to those in a little bit. Next. For these kinds of presentations, we always think that it's helpful to level set what the Medicare population looks like. Some on Medicare enjoy good health, but many have significant health impairments and limited financial resources. So half of people on Medicare live on incomes of less than about $31,000 per person per year. Half live on savings of less than $83,000 per person. 27% have a functional impairment. 22% are in fair or poor self-reported health. 18% have a cognitive or mental impairment, and 13% are under age 65 with long-term disabilities. Next. So now I'm going to talk in a little bit more detail about the Medicare Advantage program because it's become such a big part of the Medicare program overall. So half of eligible Medicare beneficiaries are projected to be enrolled in Medicare Advantage plans this year. And this is a very dramatic shift over the past decade or so. As you can see, in 2010, 25% of Medicare beneficiaries were enrolled in the Medicare Advantage program. And this enrollment is projected to grow to about over 60% in 2032. Next. The demographics of who are enrolled in Medicare Advantage plans has also shifted in the last few years. More than half of Black, Hispanic, and Asian Pacific Islander Medicare beneficiaries were enrolled in Medicare Advantage in 2020, and this number would likely be higher for 2023. So nearly 2/3 of Hispanic enrollees are in the Medicare Advantage program, and more than half of Black beneficiaries are enrolled in Medicare Advantage. And that group has seen the biggest shift from 2013 to 2020, jumping from 33% to 54%. Enrollment for white beneficiaries tends to be lower because they have higher incomes and can afford supplemental Medigap policies, and they're more likely to have insurance through a former employer. Next. So the average Medicare beneficiary has access to 43 Medicare Advantage plans. This is also a fairly dramatic shift over the last few years, when in 2018, 20 different plans were available to beneficiaries. So the number of choices available has more than doubled. This is in part because more insurers have entered the market. The marketplace has also gotten more competitive, and insurers are trying to differentiate themselves. However, because there are so many plan choices for Medicare beneficiaries, it can be difficult for them to choose among Medicare Advantage plans and find the plan that best suits their needs. Next. As I mentioned, a lot of insurers have entered the market. However, United Healthcare and Humana dominate the Medicare Advantage market. Together, they comprise 44% of enrollment nationally. However, I do want to note that there are some places in the country where other insurers are more dominant. Next. So as I talk about the Medicare Advantage program, one question you might be asking is why it has become so popular among Medicare beneficiaries. And one of the reasons is that most Medicare Advantage enrollees, nearly 70%, are in plans with no supplemental premium other than the Part B premium. And I just want to note that some people don't pay the Part B premium, such as the people who are dually eligible for Medicare and Medicaid. So for those who choose Medicare Advantage, they don't have to pay an extra premium, and typically their plan also includes that Part D drug coverage. This is in contrast to if you select a Medigap policy. Those can run $150 to $200 a month. And then people in traditional Medicare also typically purchase standalone prescription drug coverage, which also requires a premium. And I just want to call back to that earlier slide where I mentioned that that half of people on Medicare live on incomes of less than $31,000 per year. Many people live on fixed incomes, so they're unable to afford additional supplements, particularly Medigap. So that's one of the reasons the Medicare Advantage is so attractive. Next. Another reason the Medicare Advantage program is so attractive to enrollees is that plans are able to offer supplemental benefits that are not available in traditional Medicare. So nearly all enrollees are in plans that offer some sort of vision, hearing, fitness, and dental coverage. Though I just want to note that the scope of these benefits vary across plans. They are not standardized. So for example, some plans that have dental coverage might actually only cover preventive services, such as routine cleanings and x-rays, while others might cover more extensive services, such as fillings, root canals, and dentures. And plans cover a range of supplemental benefits, as you can see here: over-the-counter prescription drug benefits, meal benefits, transportation benefits, and many more. And this slide is not an exhaustive list of benefits available to beneficiaries. Next. So a question you might have is, why wouldn't anyone not choose Medicare Advantage? It seems really appealing. However, there are trade-offs for beneficiaries. So in terms of potential advantages, many of which I've already touched on, there are lower premiums than supplements to traditional Medicare, those Medigap supplements, and Part D standalone plans. There's an out-of-pocket limit for benefits covered under Medicare Parts A and B in Medicare Advantage, which there is not in traditional Medicare. There's all the extra benefits that are available that are not available in traditional Medicare, such as hearing, dental, and many more. There's a simplicity of having just kind of one plan that covers your A, B, D, as well as those extra benefits all in one place. And there's also the potential for better coordinated care. However, there are some potential downsides to Medicare Advantage versus traditional Medicare. In Medicare Advantage, there are narrower networks of physicians and hospitals. This is in contrast to traditional Medicare, where you can see any provider that accepts Medicare. In Medicare Advantage, if your provider is not in your network, you either generally have to pay more out of pocket to see that provider, or you might not be covered at all. And that's particularly true if you're in an HMO. There's also more utilization review than in traditional Medicare, like prior authorization and referrals for services. Nearly all Medicare Advantage enrollees are in plans that require prior authorization for some services, whereas in traditional Medicare, it's rarely required. There's also the potential for higher out-of-pocket costs for certain services. Medicare Advantage plans are able to modify their cost sharing for certain services. Many reduce cost sharing, but depending on the service, it may cost more than it would in traditional Medicare. There's no ability to select a separate drug plan. So if the Medicare Advantage plan that you're looking at has, and you're looking at the Part D benefits, maybe your preferred pharmacy isn't in network, you would have to decide, what's more important to you in terms of the benefits of that Medicare Advantage plan. And finally, there's a limited ability to switch back to traditional Medicare and purchase a Medigap policy. So when people first sign up for Medicare, there's an open enrollment period to purchase Medigap, and everyone is guaranteed the ability to purchase the policy. However, let's say, for example, you're in Medicare Advantage for a few years. Maybe, unfortunately, you get sick and there's a certain doctor that you want to see, but no Medicare Advantage plans in your area cover that provider. If you want to switch back to traditional Medicare, you'd be able to do that. But if you then tried to purchase a Medigap policy, you might have to pay more due to that pre-existing condition, or you might be denied coverage altogether. So again, you'd be able to switch back to traditional Medicare, but you might not be able to get that Medigap policy. I just want to be clear, there are a few states where there are exceptions, but in general, this is the situation that most Medicare enrollees would face. Next. And lastly, I just want to touch on, how Medicare Advantage plans are able to offer all of these extra benefits. And it's due to the payment system, which is very generous. So Medicare pays 6% more for Medicare Advantage enrollees than for similar beneficiaries in traditional Medicare. And despite changes, as part of the ACA, which reduced costs of Medicare Advantage plans, Medicare Advantage plans have always been paid more than similar beneficiaries in traditional Medicare. And plans are required to use some of these dollars towards reducing premiums, extra benefits, reducing cost sharing, but they are able to keep a portion towards administrative costs and profit. Next. So now I'm going to shift gears and talk more specifically about Medicare coverage of mental health and substance use disorder services. So Medicare covers a range of services, Part A, B, as well as Part D prescription drug services that help people with these conditions. So Part A covers inpatient hospitalizations for mental health needs at both general hospitals and at psychiatric hospitals. But I just want to point out that there is a lifetime limit of 190 days in a psychiatric hospital in Medicare. And again, that Part A deductible for benefit period applies, as well as daily copays. Part B covers a range of benefits that can help with that help address mental health and substance use disorder needs, including individual and group psychotherapy, family counseling, psychiatric evaluation, medication management, Part B drugs. Part B drugs are those that are typically administered in physician offices, as well as telehealth, which I'll talk in more detail about next. And for those services, the Part B deductible and 20% coinsurance apply. Then there are some other services that have different cost sharing amounts. So there's Medicare covers a yearly depression screening for no cost sharing. There's also a Welcome to Medicare visit in the first 12 months of being on Medicare, where a provider can screen for depression and other mental health conditions, also with no cost sharing. Similarly, an annual wellness visit, which happens can happen every year, also can screen for certain conditions, does not require any cost sharing. Medicare also covers partial hospitalization. After meeting the deductible, beneficiaries pay coinsurance for each day of partial hospitalization services they receive. And then Medicare also covers benefits more specifically towards substance use disorders, such as opioid use disorder treatment, alcohol misuse screenings, and tobacco cessation counseling. And no cost sharing is required for those services, as long as the provider accepts assignment. Next. So Medicare covers telehealth for mental health and substance use disorder services. Before the pandemic, telehealth services were available only to Medicare beneficiaries in rural areas originating from a healthcare setting, such as a clinic or doctor's office. So that means that prior to the pandemic in general, Medicare beneficiaries could not get telehealth in their homes. One exception for substance use, there was one exception specifically for substance use disorders that went into effect July 2019. So people could, anywhere in the country, in their own homes, could get telehealth benefits if they had been diagnosed with a substance use disorder. Further, these geographic and originating site limitations did not apply to Medicare Advantage plans as of 2020. So for beyond just mental health services, Medicare Advantage plans can offer telehealth benefits to people anywhere in the country in their own homes. During the pandemic, Medicare has since permanently removed restrictions for telehealth mental health services. Medicare also covers audio-only visits for mental health and substance use disorder services, though there are some limitations. However, I do want to note that with these new allowances for telehealth mental health services, there are some in-person requirements, such as an annual visit in person with a provider. However, these requirements have been delayed as part of the Consolidations Appropriations Act until January 1st, 2025. So currently, people with mental health conditions can continue to get their telehealth benefits, and they do not have to go in person. The expanded coverage for non-mental health services will expire December 31st, 2024 as part of the Consolidations Appropriations Act. So without a change in law for other for other telehealth services besides mental health and a few other small exceptions, people in traditional Medicare will no longer be able to get telehealth services unless they live in rural areas and go to a doctor's office. Next. And then I just want to touch on coverage of mental health and substance use disorder services and Medicare Advantage. As I mentioned earlier, Medicare Advantage plans are required to cover all Medicare Part A and B services that traditional Medicare covers. So all of the services on that slide before that I showed, but they do have the flexibility to modify cost sharing for most of these services. Again, Medicare Advantage plans mostly include Part D, which covers outpatient drugs needed for these services. However, Medicare Advantage plans may provide supplemental benefits for these services that are not covered by traditional Medicare. So some benefits, say some things like transportation, is a benefit that can be used for both regular medical services and to mental health visits. In addition, there are supplemental benefits that are more specific to mental health conditions, such as providing extra days to a hospital stay, for example, that traditional Medicare wouldn't cover. Medicare Advantage plans can require provider referrals and impose prior authorization for mental health and substance use disorder services. However, I do want to caveat that, just be clear that prior authorization is not required in emergency situations. And enrollees in Medicare Advantage plans, again, are limited to receiving care from providers in their network, or they must pay more to see out-of-network providers in most cases, or they're not covered altogether if they don't have any out-of-network coverage in their plan. Next. So this slide just mostly reinforces the point that most Medicare Advantage enrollees are required to receive prior authorization for mental health and substance use disorder services. And while prior authorization can prevent the use of unnecessary care, it can lead to delays in receiving needed care. So 94% of all Medicare Advantage enrollees require prior authorization for an inpatient hospital stay at a psychiatric hospital. 92% require prior authorization for partial hospitalization. 85% of enrollees are in plans that require prior authorization for psychiatric services, mental health specialty services, opioid treatment program services. And psychiatric services are individual and group therapy with a psychiatrist, while mental health specialty services are individual group therapy with other types of providers. Next. And finally, I just want to wrap up with some recent policy changes, as well as proposals to improve access to mental health and substance use disorder services in Medicare. So there were many changes in the Consolidations Appropriations Act, but I'm just going to focus on two of them. One is the definition of partial hospitalization in Medicare. So the law clarified that it is for individuals who need these services for a minimum of 20 hours per week. Medicare will also, beginning in 2024, cover intensive outpatient services, which are the same as partial hospitalization services, but only for those who need them a minimum of 9 hours per week. And most relevant to you all, Medicare will directly reimburse marriage and family therapists and licensed professional counselors for the provision of mental health services. And of course, Matt will talk about that next. And some recent proposals that have been floated but have not been implemented would be applying the Mental Health Parity and Addiction Equity Act to Medicare. Currently, federal parity laws do not apply to Medicare. Eliminating that 190-day lifetime limit on inpatient stays in a psychiatric hospital, as well as covering 3 behavioral health visits without cost sharing. Next. And with that, I will turn it over to Matt. Thank you.
Thank you very much, Meredith, for that comprehensive overview. This is information that we definitely need. So thank you so much for joining us today, taking the time to join us today. I would now like to welcome our second speaker for the day, Dr. Matthew Fullen. Thank you.
Thank you, Jolie. It's a pleasure to speak with all of you today. It's a really exciting time in the history of the counseling profession. And so I want to acknowledge that we've really come a long way. Prior to this recent legislation, the last time the Medicare mental health provider regulations had been updated was in 1989. And so the legislation that was passed in December of 2022 marked a modernization of Medicare mental health that will benefit older adults and people with disabilities who rely on the Medicare program for access to mental health care, as well as to the over 200,000 professionals, mental health professionals, who will be added or have the opportunity to be added to the Medicare program starting in January of 2024. Like many of you, I have a history of interest in how to serve these populations of people as a licensed counselor. I can remember some of my early professional experiences where I was positioned in places where older adult clients were made available. And I'll never forget one situation where a client, a woman in her 80s, and I had been working together for several months on depression and anxiety. She had been making great strides, and her service, the services were being covered through her state Medicaid plan. And I'll never forget one day receiving a phone call from my supervisor in which that person said, "I'm sorry, but due to some change of circumstances, that client is no longer available to work with you because their Medicare insurance has now become primary, and you need to stop working with her as of right now." Incidents like that, which I know have impacted many professionals over the course of your careers, are the reason why we embarked on this advocacy over the last nearly 20 years to try to change the law. And I'm so pleased to say that the law has now changed. And now we're in this critical phase of implementation and of trying to work closely with the Centers for Medicare and Medicaid Services to ensure that this is implemented in a way that will provide the most appropriate care possible for beneficiaries, and will give you as licensed professionals the same sort of opportunities professionally as many of our allied mental health professionals have. So on the next slide, I want to share just a little bit about the mental health needs that older adults face. There's a lot that goes into this, and we know that Medicare doesn't exclusively cover older adult clients, but as Meredith mentioned, about 87% of Medicare recipients are 65 years or older. And so I do want to note that in general, older adults have a high rate of life satisfaction. There's nothing about aging itself that leads a person to feel depressed or anxious. And in spite of that, though, we know that like any age group, older adults may experience mental health distress. And this can either be as part of a long-term kind of a chronic struggle with mental health conditions, or it could be the first time that an individual has experienced some form of mental health distress that may be occurring now that they're in some of the later years of life. We know from recent research that roughly 1 in 5 older adults is experiencing anxiety, depression, substance use, insomnia, or another mental health disorder. We also know that there's data suggesting this has worsened since the pandemic. The same study that came out of the University of Michigan and was really looking at mental health among older people, particularly as the pandemic had influenced it. Same study found that the majority of these individuals were interested and open to mental health services, but in many cases did not have access to those same services. And of course, that study was conducted prior to this recent Medicare legislative change. And so I think there is a bright future ahead of us as we think about the ways that professionals from the counseling and marriage and family therapy disciplines can begin to really use your skills and your expertise to provide help and healing and hope to a population of people that has historically been underserved. We also know that in some cases, older adults struggle with more severe mental health distress. And when you look at suicide rates over the course of the lifespan, consistently, older adults have a higher than national average rate of suicide, and older adult white men over the age of 85 routinely have one of the highest per capita rates of suicide in the country. Demographically, the number of older adults in the American population as well as the global population has been on a steady increase, and that will continue to be the case for the foreseeable future. So as we think about the timeliness of this legislative change and the opportunities that it provides for professionals like ourselves, please do keep in mind that we expect there to be a consistent and growing number of older people, as well as people with disabilities who rely on Medicare, who are seeking mental health services from professionals like yourselves. We also know that as the boomer generation ages into older adulthood, roughly seen about 10,000 people turn 65 every single day currently, that more and more we anticipate that these are individuals who may have come of age at a time when mental health services were more customary, were less stigmatized than maybe they were in previous generations of individuals. And so for that reason as well, we believe that there are many opportunities that await our professions to serve the growing needs of this population. Next slide, please. So as you probably know, but I do want to reiterate, the Medicare mental health law is in the process of changing. And so when Congress passed the Consolidated Appropriations Act on December 22nd of 2022, and President Biden signed that into law on December 23rd, 2022, that did set into motion the implementation of new mental health law within the Medicare program. And so the Mental Health Access Improvement Act, which was the bill that informed what was covered under the Consolidated Appropriations Act, allows mental health counselors and marriage and family therapists to diagnose and treat older adults and people with disabilities who are covered by the Medicare program for their mental health care needs. It allows us to diagnose and treat individuals with substance use disorders who are covered by the Medicare program for their behavioral health needs. It allows us to serve individuals who rely on Medicare on top of another form of health insurance, and that covers individuals who may be dually eligible for Medicare and Medicaid. It may be certain segments of the veteran population that have Medicare insurance alongside other forms of insurance. And as Meredith described, individuals who may have supplemental insurance programs that look to Medicare as the primary insurer are also added to the mix of people that we're talking about. Prior to this legislation, we know that many mental health professionals who were not recognized by the Medicare program would have trouble working with individuals who relied on Medicare, even if they had a supplemental insurance coverage or Medicaid, and even if those professionals were eligible to work with these other programs, the fact that we were not recognized by the Medicare program created a barrier that in the vast majority of cases was not surmountable. So the legislation not only allows us to participate in Medicare Part B, it also removes this primary barrier to participation in Medicare Advantage, some of the Medigap solutions that Meredith described, as well as these other instances like Medicare and Medicaid, where many professionals, many counselors and marriage and family therapists were recognized on one side of the fence, but didn't have the commensurate Medicare recognition that opened the door to services for clients that you served. All of this really does boil down to receiving payment under the Medicare Part B program, as well as these other programs, such as Medicare Advantage, for providing covered mental health services to Medicare beneficiaries. And the key date that is outlined in the legislation is January 1st, 2024. In meetings with CMS, they're very aware of that date, and there are efforts underway to provide the sort of on-ramp that will be necessary so that leading up to, the days leading up to January 1st, 2024, there will be more and more communication coming from CMS, as well as through organizations like NBCC or the Medicare Mental Health Workforce Coalition, to ensure that providers know the exact steps that are needed to enroll in the Medicare program. Next slide. Now, it's important to note here that the Medicare inclusion that is now law represents a broad variety of treatment settings. So, many counselors and marriage and family therapists work within agency or private practice settings where you may want to enroll as a Medicare provider so that you can serve Medicare recipients through their Medicare Part B or through some of those Medicare Advantage plans that were previously discussed. And that is certainly a major component of how we see the Medicare coverage unrolling. In addition to that, it's important to note that this Medicare legislative change also opens up access to Medicare beneficiaries seeking out mental health care within federally qualified health centers, within rural health clinics, within the hospice program. So the legislation provides a provision that adds counselors and marriage and family therapists as part of the interdisciplinary team that hospice programs can select from. And so, in theory, then a hospice interdisciplinary team would, have to either provide access to a licensed clinical social worker or a licensed counselor or a licensed marriage and family therapist. Additionally, Medicare integrated behavioral health programs and primary care programs, Medicare innovative delivery and payment programs, as well as telehealth services, as Meredith described. So when we think about Medicare inclusion, there is going to be a lot of interest and a lot of questions about how to make this actionable for the client populations that I serve in the exact setting where I currently work. But please keep in mind that there are these additional horizons where being at the table as part of being a Medicare affiliated profession now does allow us to speak on behalf of the counseling and marriage and family therapy professions when some of these other innovative programs are being developed. And these are opportunities that historically we have not had due to not being recognized within the Medicare program. So you may not work within those settings today, but these may open up additional opportunities for new client markets, as well as new employment possibilities that may interest you down the road. Next slide. In terms of rates, this is something that there's a lot of questions related to, how the Medicare program reimburses. So the way that this typically works within mental health care, services are reimbursed at 80% of the lesser of the actual charge for the services, or 75% of the amount determined for payment of a psychologist. That is commensurate with what licensed clinical social workers currently receive under the Medicare program. And as I referenced earlier, in 1989, certain restrictions related to psychologists were removed and licensed clinical social workers were added to the Medicare program. So when we were tracking the way that the legislation unfolded, the benchmark that has been used is to look at not only reimbursement rates, but also CPT codes and things of that nature that are currently being used within Medicare for licensed clinical social workers and to a degree psychologists as well. These rates in terms of the specific dollar amounts are determined annually by CMS as part of the physician fee schedule. And so that is released, projected to be sometime in July roughly, and then that triggers a 60-day window for public comment where organizations and individuals can respond to the physician fee schedule, the rates, and many other details related to how these programs come together. And the public can respond to those and provide CMS with feedback. And so stay tuned for that. That will be a really important juncture in how the implementation process pans out. Next slide. So as I previously alluded to, there are just major implications for inclusion within the Medicare program. First and foremost, this means that we are expanding the provider pool for underserved clients. And that is critically important to counselors and marriage and family therapists who really pride themselves on providing services to people who would otherwise maybe have trouble receiving those services. It creates new populations of clients to serve, and hopefully that expands the pools of individuals that you may have an interest in working with. It provides an enhanced continuity of care for individuals who transition from non-Medicare insurance to Medicare insurance. And we know over the years prior to the legislative change, many professionals had issues where they would be working with a client, that client would turn 65 or would qualify due to a disability, and then all of a sudden not be able to work with that individual anymore. So this provides continuity of care for clients. It also provides parity among mental health professionals. So having a seat at the table as the Medicare program, which is the largest insurer in the country when it comes to things like mental health care and opioid treatment and any number of things that we as mental health professionals care deeply about. It's really important for us to be at the table as decisions are being made about the future of these programs. And it provides expanded professional opportunities for counselors and marriage and family therapists. So some key next steps, I mentioned July when the physician fee schedule is anticipated to come out. I imagine there will be correspondence that comes out on behalf of organizations that comprise the coalition to make sure that we are being very responsive once we know more of those details in terms of how CMS envisions rolling this out. And this will also provide detailed information regarding the exact procedural codes that CMS is attaching to the legislation. But broadly speaking, mental health services that are currently provided by licensed clinical social workers and psychologists, we would anticipate the vast majority of those also applying to licensed counselors and licensed marriage and family therapists. Thank you so much, and we look forward to hearing some questions from you shortly.
Thank you, Meredith and Dr. Fullen, for sharing your time and your vast knowledge with us today. There is so much to absorb and learn as we go on this journey together. We're really at the tip of the iceberg on this, so they say. We wanted to provide you a few resources before we head into the question and answer period. So the next two slides, well, actually one is there now, include resources related to Medicare in general, and also specific topics such as beneficiaries, enrollment, the physician fee schedule, and reimbursement rates. And Matt touched on a few of those as well, but we wanted to give you some links to look at before we have our next webinar as well. While we do not know all of the answers specific to counselors and MFTs yet, we can share information that providers typically follow with CMS. And these topics that we're sharing here are going to be covered in more detail during the May 5th webinar. But please enjoy these resources in the meantime. So now we'll move into the question and answer portion of our program. The speakers, of course, are not going to be able to address all of the questions. We've had a lot of really good ones come in. So I'm going to read out a couple of those, and then Dr. Fullen and Meredith can go back and forth as to who might answer these. I do want to say, too, that we're going to be collecting all of these questions, even though we can't get to them, and then that's going to further inform the May 5th webinar content. So I wanted to let you all know that as well. So let's start with the first question, and I think this will be for you, Meredith. Why are some Medicare Advantage plans not charging premiums? What is the catch, and where do patients end up paying?
Sure, yeah, so plans aren't charging premiums. It's partially through the payment structure. So plans bid against a benchmark. And often their bids are below the benchmark, and they get the difference between the bid and the benchmark as a rebate. It's a little complicated, but when they get these rebate dollars, they have to use some of them towards either reducing premiums, providing extra benefits, or reducing cost sharing. So they're not able to retain all of this rebate dollars as profit. And so that's how they're able to offer those extra benefits for no additional premium.
Okay, thank you for that. Some of the questions are complicated to answer for sure. So thank you for that. The next question that we have is, what does it mean when it says if a provider accepts assignment? Can either one of you speak to assignment?
Yeah, so I can't remember exactly. There's kind of like 3 different designations for Medicare providers. And one is accepting assignment, which basically is fully enrolling in the Medicare program, meaning that they have to submit, submit all claims to Medicare and can't charge different Medicare rates for those services. There are some other, I'm trying to recall what the kind of middle tier is. I don't know if you remember that, but then people can opt out of Medicare. And so those providers would not be considered as accepting assignment.
Okay, thank you for that. Dr. Fullen, I think this one might be for you. How do I know as an MFT or counselor if I'm an eligible Medicare provider?
Yeah, it's an important question. So I'm going to reference the legislation itself because this is what Congress has directed CMS to use when implementing the law. And so this is what should inform the way that CMS describes and administers the change in the law. So what the law officially says is that for individuals such as licensed or mental health counselors and marriage and family therapists, these are individuals who are legally authorized to perform under state law of the state in which such services are performed, as would otherwise be covered if furnished by a physician or as an incident to a physician's professional service. And those details are not quite as directly relevant. So the way then that the law describes a marriage and family therapist is an individual who possesses a master's or doctoral degree, which qualifies for licensure or certification as a marriage and family therapist pursuant to state law. As well, after obtaining such degree, has performed at least 2 years of clinical supervised experience in marriage and family therapy. And part 3, in the case of an individual performing services in a state that provides for licensure or certification of marriage and family therapists is licensed or certified as a marriage and family therapist in such state. And the law provides almost a verbatim description of mental health counselor. So again, it's a master's or doctoral degree in that in mental health counseling or related field, has performed at least 2 years post-degree of supervised mental health practice, and is performing that within a state under the licensure or certification, depending on how that state operates. So those are the key kind of categories. I imagine there will be some edge cases that pop up, and we will continue to make ourselves available to try to help people sort through those. But in the vast majority of cases, degree, licensure, and 2 years of post-degree experience.
Very good. Thank you, Dr. Fullen. We've had quite a few questions come in about telehealth, so now I'm going to use one of those. And that one is, can you speak to the difference in reimbursement for in-office and telehealth and reimbursement differences by provider? Example, Blue Cross Blue Shield and United are significantly different in their rates to providers.
I'll take a stab at this. I think, that, we've sort of seen that general reimbursement, but, between Medicare, traditional Medicare and Medicare Advantage plans, to providers is similar, but Medicare Advantage plans, do have flexibility, in terms of, reimbursement rates. So yes, provider, reimbursement can vary, depending on the insurer. So that is, something to be aware of in terms of the Medicare Advantage program.
I'll add that CMS employs a series of Medicare administrative contractors, or MACs, and those entities are charged with administering the program within certain regions across the country. And so as we get deeper into the implementation phase, so the physician fee schedule released, opportunities for that to become final rule, and then opportunities for enrollment to start picking up, there will be more opportunities to learn about the role of these administrative contractors as they are kind of making sure that implementation is happening within your region. And so while there may be certain things about the Medicare program that are standardized because of it, being a federal legislative change, there may be certain things that are, particularly relevant to where your practice is, and some of those features and how that could have an influence on things like Medicare Advantage rates and some of those nuances.
Very good. Thank you. I think we have time for one more question. So this is the last one. Do you anticipate barriers or obstacles for MFTs and counselors in joining Medicare Advantage plan networks? And can new regulations require plans to have more open networks?
Yeah, so the barriers, as I would envision them, is primarily just the time that it takes for CMS to incorporate a new law and then to fully understand some of the ramifications of the new law. You as an individual provider may be more tuned in to the ways that the law will, specifically impact your practice, but CMS is trying to think about this from the lens of what was passed by Congress. How do we put this into a plan that is actionable, that speaks to the breadth of the nation's providers? So one kind of rubber meet the road issue with this is that each year there is, CMS will solicit information about Medicare Advantage and the way that Medicare Advantage is rolled out. And as sort of a quirk in just the timeline of how these things work, the Medicare Advantage solicitation happened earlier in 2023, prior to really any opportunity to respond to that. So because the legislation change was passed so late in the calendar year, there is a little bit of catch up that has to happen so that the counseling professions and MFT professions can communicate to CMS all of the various ways that we anticipate not only the legislative change, which has much clearer timeline attached to it, but also these kind of next level consequences like Medicare Advantage that need a little bit of time for CMS to wrap its head around. Okay, so if we've changed how Medicare Part B works, then we're going to probably need to change Medicare Advantage regulations in this way. And so our hope is that by communicating as much of that as possible proactively, we get out ahead of this and can really help to kind of inform CMS about the needs of our stakeholders. But some of those details and exact timelines, will have to remain to be seen.
Yeah, and that's great, Matt. And just to build off of that, especially in terms of timelines, so there's an annual bidding process for Medicare Advantage plans. So, that aligning with, getting providers into Medicare Advantage plans will be important. So there might also be sort of an educational component that's necessary to sort of remind plans that this change is happening and, to incorporate these types of providers into their plans. Yeah, so I would just say that might be an element as well on your end of things, is reminding them that we're here and we can be supportive of sort of the and address some of these workforce shortage issues.
Wonderful. Thank you both for answering those questions. We are out of time for questions now, so the Medicare Mental Health Workforce Coalition and NBCC would like to thank our speakers, Meredith Freed and Dr. Matthew Fullen, for sharing their knowledge, and all their participants for attending today's webinar. The link to the session evaluation is now posted in the chat. To receive continuing education credit, you must complete the evaluation by April 27th at midnight Eastern Daylight Time. Certificates will be emailed a few days following the close of the survey. We will only be providing credit for the live attendance of this webinar. We hope you found this session informative, and we look forward to seeing you all during part 2 of the series, Medicare 201, the implementation of Medicare Part B coverage for counselors and marriage and family therapists, on May 5th from 4 to 5 p.m. Eastern Daylight Time. The registration link is posted in the chat. Thank you and have a wonderful day.